care for the folks on the west side. So they built four of them got together, they built a home, small 20 beds, and then when it was finished, my dad looked around and said, well, I'm the carpenter, I'm the contractor, who's going to run this facility? One was a physician, the other fellows were businessmen, and they all looked and said, we can't do this, we don't have time. So my mom and him got together, opened the place up. Shortly thereafter, they bought them out, and then they expanded. So that was in '62. Today, we have 5 facilities, and the folks in the facility in Bay Village has assisted living as well as memory support, and then the other 4 facilities also have assisted living and independent living and dialysis and different services.
And when did you come into the business, John?
In 1979, I got my license. We had a home down in Delaware, Ohio, a little bit north of Columbus, and I lived there for 5 years. Moved back to the area.
Learned in the business, huh?
Yeah, I was the administrator in that facility, and then I moved back up here and we started adding on.
Speaking of that, John, administrator, what does that mean exactly?
It's a program that's licensed by the state of Ohio. A lot of folks now are coming out of universities, Bowling Green State University, Cleveland State, OU. They all have programs. Kent State have programs. The students graduate with a 4-year degree. They are eligible to sit for their exam. They take the exam. They've gone through an internship, and then they're eligible to work in a nursing home anywhere within the state of Ohio. It does transfer from state to state. Ohio is recognized as a state that has a very strong licensure program, so they can pretty much go to any state in the union and work as a licensed nursing home administrator.
So this would be a good career path.
It's an excellent career path. We employ a lot of young administrators now in our facilities. A lot of them start in different roles, whether it's admissions coordinators or social service people, and then they move up the ladder and become an administrator.
So you don't have to have any type of medical degree.
You have to have this 4-year degree and sit for the license and pass the exam.
So would there be medical terminology and that kind of stuff? You'd have to know a little bit about medicine, right?
Yeah, the curriculum covers gerontology, covers terminology, physiology. It's quite intensive, as well as in marketing and business and kind of a well-rounded psychology.
How about nursing? Is there a little bit of nursing in it?
That's covered in the physiology courses.
But do you need that to get the degree?
You don't need a nursing degree to get the degree. This is a separate degree, and a lot of state universities offer that degree now. Currently, we have we have people from OU, from Kent State, from Bowling Green that are working with us now.
Nursing home care, John, has changed probably a lot since your dad started that business way back in 1962. And how important is it for people, ordinary people, to be thinking about what's going to happen in the future when their parents or their grandparents get older? How do they start thinking about it? When should they start thinking about it? Or when should people, all of us, start thinking about nursing home care?
Well, I think it's one of these topics in life that we probably don't discuss until we're found that we need to look for that type of care. And in our profession, we are not only caring for kind of what most people think is a traditional nursing home care where people are long-term staying with us, but also with the healthcare is changing now where you're in the hospital after a fractured hip or an exacerbation of a chronic disease, and then the hospital length of stay is only 1 or 2 or 3 days, and then they're saying, well, you can't go home, you need to recover. So they come to our skilled facilities and might be covered by their insurance or Medicare, stay with us for 2 weeks or 5 days, some period of time where they can regain their strength, and then take advantage of our therapy, and then be able to go home safely. Then we have independent living, we have assisted living, we also have memory support as well, where people are confused enough where they can't really maintain their life at home. They don't have the caregiver structure at home. They need to come to one of our facilities. So there's different levels of care that we offer. All of these facilities throughout the nation are really in the neighborhood. They're cared for by folks that live in the neighborhood, so they're part of our fabric of our community. They have different activities of people coming in and bringing their dogs, and churches having church service, theater groups doing their rehearsals. So we need to be aware of these facilities in your neighborhood, because you never know in any situation what you might have where you'll be utilizing that service.
Is there an average stay that the average person is going to end up in a nursing home? Do they have any data on that?
I'm sure they do, but I'm not aware of it. Because it affects so many different people in different walks of life. But obviously, if someone, because of the shorter length of stay in the hospitals, people are going for that short-term stay. There's certain statistics out there, I'm sure, that for people with memory support, so long-term care. So there's different levels of care, different services that are offered that probably there's different statistics out there. But I think for overall, more and more people are utilizing our services because of the broad array of services that we do offer.
Because of your knowledge of the nursing home business, I heard many years ago people say, especially West Siders, if you have to go to a nursing home, make sure you go to O'Neill's. It's one of the best places around. How did you get that great reputation? And you still have it today, I can tell you.
Well, I mean, when my father started, one of the things that he wanted to do is he looked around and thought, well, he can do a better job than the other facilities in the area. And it was just something that we always thought we wanted to strive for the best. I remember my mother saying, shoot for the stars and you'll end up at the moon. So you just want to set high standards. I grew up in the family business, if you will, something that I've chose to do. My children are involved in the business as well. And we're very proud of what we do, and we're caring for our community members. We certainly aren't hiding behind a corporate name or anything, and we're out there providing care and very proud of what we do, and have served a lot of people in the community. And people want the best for their family, and we want to provide that best care as well.
Well, the first one was where?
Bay Village.
In Bay Village. And then you expanded. I want to come back and talk to you more about that, John, of how you select the locations of where you're going to put your nursing homes. We'll talk more. Important subject to discuss these days is talked about on radio and television every day, John. Healthcare and immigration seems to monopolize the news these days, doesn't it?
Yeah.
And nursing home care fits right into this. One of the dilemmas that the wife and I had years ago was whether we should buy long-term health care or not. What's your thoughts on that?
That's a policy that is offered, and it basically is a policy, and I'm sure you and your wife went through this, that they offer that if you pay a premium, that if you are in need of nursing home care, that policy will pay for portions of that care. Mm-hmm. So tell me, Jerry, do you remember what the premiums were in your mind? Was it high, low? Was it?
Well, when I bought long-term health care, I think I was in my 50s, and that was 20 years ago. Mm-hmm. It has tripled. The premiums have tripled. For me, especially, and I think they've gone up like 2.5 times for Nellie.
Yeah, so it's
gone up a lot.
It's an expensive policy.
It's very expensive.
Yeah, and I think that what we see is there. Excuse me, did you buy the policy, or did you just look at it?
Oh no, I bought it.
Okay,
so I still have it.
Okay, so what we have found is that those policies don't pay that often. In the scheme of things, when we look at all of our residents in our facilities, not many of them are covered by their insurance policy. So the important payers that are involved when you're thinking of this is that Medicare does pay for that short-term rehab stay. So those are the patients that come to us from the hospital, have had a fractured hip, the father that got in the auto accident, he's going to go to rehab. He might come to a facility like ours where he's going to be offered several hours of therapy a day in order to get better to go back home. So that's one example. In that example, an insurance company might pay, Medicare might pay, the Medicare Advantage policies might pay, and those are the payers that pay for that short-term stay. They're going to pay for a week or two till the person gets better to go home and live independently at home. The people that are staying with us long term, those are the people that would be paid under your policy. They don't pay for that short-term stay, they're paying for the long-term stay. The primary payer in that arena in our facility is Medicaid. That's the state-run program that's funded 50% by the federal government and 50% by the state government. And that is the payer that pays for people that are long-term, and by that I mean an average length of stay is maybe 2 years kind of thing. And that's where your policy would pay. And that's the insurance policy that you talk about.
Right.
And when you talk about percentages of who's going to end up in that home, that's a very hard thing to predict. I would say over the age of 85, maybe your chances of being a resident in a nursing home for the long term is greater than someone who's, let's say, 55, because we don't know what's going to happen. I usually tell people that depending on your physical and your history, what was your parents' health in their latter years? And if someone, and I talked to one lady and she was pretty clever about it, and she said my mom and dad both had Alzheimer's and were in facilities when they were in their early 70s. So she felt that she had a high probability that she might end up in the same situation. And I think that everybody in the medical field would agree that her chance of ending up in a facility if both her parents contracted a memory Alzheimer's type disease, then she had a high probability compared to someone whose parents maybe lived till in their late 90s and didn't have any of those issues. So that's a hard thing to predict in life, but that's certainly an indication.
Yeah, I did notice that the long-term care, the increase was huge. In fact, what I did was I reduced the benefits a little bit to keep the price down.
Mm-hmm.
And they gave me that option.
Yep.
I don't know how long I'll be able to afford to do it. If I can get the station to pay me more money, maybe I'll be able to do it.
A big radio DJ like yourself,
Yes.
I'm sure.
Yes, I know they'd love to hear that.
Yeah.
No, this is a non-paying job here. I don't want anyone to get the wrong impression here. We just do this. Really, we do it all for fun and all the people that work with me. And again, sponsors like you, John, make an huge difference. We couldn't do it without our sponsors like yourself. And thank you for coming on as a major sponsor here on the Irish program.
Thank you for having me.
And this I think this is very useful to what we're doing today. I'm sure there's a lot of people calling their friends saying, you got to listen to this because it's something that affects just about everybody sooner or later.
Yes.
Would you agree? Now, John, I have a song here that was written by a friend of mine called Cathal Dunn. And he wrote it because his mother got Alzheimer's. And it's called The Long Goodbye.
Truly a difficult thing because it's very slow disease that progresses, so therefore ones have cared for a loved one in their home typically, and they realize that it's difficult for them to continue that care.
It's difficult for the family, isn't it? Very difficult for the family.
And without a primary caregiver in the home to care for them, it's hard to keep that up in the home. And I think, a lot of people just kind of touching on prevention, early diagnosis. There's been a lot of advances in the early diagnosis of Alzheimer's, and there's been some pharmacological breakthroughs where they kind of can slow that down in the early onsets that are useful. That's why you have to get to your family physician and keep on track in that respect. And then I think as we're younger, we have to think about that. I think what's important is being physically active, a proper diet, so when you approach your older years, you're physically fit and you're ready to come into that stage of your life, that you have your weight under control physically, you've been exercising, you keep the blood flowing to the brain, and you remain healthy. So if something like that does come into your life, that you don't have any other problems that might complicate it.
I think it's a good thing to stay busy, even in your older years, doing something, keep the brain and the body active.
Yep. I think a lot of people have been looking at crossword puzzles and Sudoku and all that. I think that's a very small part of it. I think getting physically active is more important.
Margaret, I'm going to want to give away one of these treasures, these masterpieces, this book that you, once again, let's talk about the various nursing homes in the various areas they are. How did you pick those areas? Or why did you pick them?
Well, as I said before, my father was in Bay Village building houses. He was a carpenter. He immigrated from Ireland in '48, the year the
County Carlow.
County Carlow. The year the Indians won the World Series, he came when they had the parade going. He said, "This is a marvelous city," and so he stayed with his dad's sister in Parma, and he was on his way to Australia and met my mom and she decided no, Cleveland didn't want to go to Australia, so that's what kind of kept him here in Cleveland. And he was building homes, like I said, on the west side, and that's what convinced him to buy some land in Bay Village and start there. After that, we built our second facility in North Ridgeville, and that was an area that we felt that there was a need there, and that was opened in '86, and that's when I was there
And
involved
it was
in that.
starting to be a growing area, wasn't it?
It was, yeah. And North Ridgeville is a pretty growing area, and of course Avon and that area of the county, the eastern end of Lorain County. We then purchased some land at Clegg and Brook Park and built our North Olmsted facility. And that started out as an assisted living facility, and it now has 56 skilled beds as well as the assisted living and a memory support. And then we went on to, and we purchased a facility in Lakewood, that's at Bunce in Detroit, and that has three independent living buildings, one assisted living facility, and then the nursing home, and that has a dialysis unit as well. And then we built a facility in Fairview Park right across the street from City Hall, pretty close to St. Angela's Church. And kind of what sets our facilities apart, and of course we talked about Alzheimer's, we've talked about long-term care, but it's the rehab component. All these facilities have full-time therapists that offer physical, occupational, and speech therapy, and a lot of people come from the hospital for a short-term rehab stay before they come home. And that's a good way to kind of build up the strength, get all your medical and your medication all stabilized before you go home and have a successful recovery at home.
Who decides where a person goes? We'd say if you're going to a doctor and you need rehab, is it the doctor says, or could the patient say, well, I want to go to one of the O'Neill facilities?
Well, it's always the patient choice is number one. If the patient wants to go to a particular place, the healthcare professionals always rely on the patient's choice as number one. Most of our people are coming from the hospital. We have on average 10 admissions a week at each of our places of people coming in for short-term stay. And they are typically in the hospital. They've seen either their family physician or they've seen a hospitalist. Maybe they've seen a specialist that they've just met for the first time in the emergency room. But all of those people play a part in recommending where they go. Their insurance obviously has a list of networks. O'Neill Healthcare, we have most contracts for all insurance companies. But that decision is made at that hospital level. If the family is prepared, if the family's done their their kind of their homework of what facilities are involved, and they recommend a place, the practitioners usually agree with what the family chooses if it's appropriate.
Since you have come into the business, have you noticed a big change in, we'd say, the paperwork and the regulations? Talk to me about that.
Sure. I think any of us who've been in healthcare, I hate to admit that I've been in the profession as long as I have, because I don't think I'm that old. But that being said, I think the paperwork, I remember one time I was listening to a hospital person being interviewed on the national news and said the amount of paperwork we have to go through, that the hospital, the nursing homes that we hire to do our paperwork, to submit a bill, the insurance companies, they review it. Everybody's looking at it. Everybody's tossing it back and forth, and we're just absolutely buried in paperwork. So it is a monumental problem, and we've got lots of people that are shuffling paper.
But doesn't that add to the cost, the bottom line, eventually?
Absolutely. It's a constant battle to kind of make things streamlined, to reduce that paperwork chase, but unfortunately I think it's here to stay. We talk about paperless, we talk about one medical record for everyone nationwide, but in retrospect we've got different hospital systems, different nursing homes, everybody's got different software, none of it talks to each other.
I remember a few years ago when Highland Software started, they were into the electronic records. And I thought that was going to solve all of that you could go into a hospital if you got hurt and you lived here and you went into a hospital in San Francisco, that instantly like that they had your medical records. Is that true?
No. So Highland Software is a popular software that is used in the healthcare profession.
On base, right?
Yep. And then the other one is, I don't know, should we mention names? But anyhow, Epic is a big software developer outside of either Wisconsin or Minnesota or somewhere up that neck of the woods, and that's what the clinic uses. We've got different software that we use, that the nursing homes that's a kind of a winner in the market share of nursing homes, which is called point-click care. And then you have the federal government wanting to protect your health information, that it's your information, that we don't disclose it unless the party's involved in delivering care. But yet that's kind of crippled us, that no one wants to be disclosing your information to anyone else. So that's even made it harder to share and collaborate to deliver care. So there's some success stories out there, but then there's other stories where it's kind of hard. We don't have that. If you did go to another hospital system here in Cleveland, you wouldn't even, your practitioner there wouldn't be able to get that information.
But you have to have all the capabilities of doing all this, following these regulations. So you have to do it, huh?
You have to
you
do
won't
it.
be in business.
Correct. But the good thing is that if we have our relationships, and in this town, obviously we have the clinic and we have UH, we have relationships with them, and then we can share medical records with those two main providers.
They're the main providers.
Yep.
God, it's a complicated system. The nursing home business, it's no accident that O'Neill Healthcare, that O'Neill nursing homes have a wonderful reputation. And I'm saying that, John, without sincerity, because I've never heard any anything to the contrary about your nursing home. But that doesn't happen by accident. That takes a lot of hard work.
That's correct. I mean, there's a lot of great people that work for our organization, and they're the people that provide the care directly to the residents. And without people like that, you don't earn that reputation. So it's something we strive at every day. There's all kinds of government regulations and government polls and ratings and that kind of thing. But nothing beats, if you're going to evaluate a facility, that you walk in, you take a look at the building, going in on the weekends, going when there's a meal time. And, it's not complicated. Cleanliness is important. Looking at make sure people are saying hello, whether it's a staff member or residents that are there. It's a home, so it should feel like a home.
Mm-hmm. Getting the staff, do you have a lot of training to do with them? Or do you look for people that are already trained, I suppose?
Right. There's obviously, when registered nurses, licensed practical nurses, physical therapists, cooks that have had some training in safe serve and sanitation. There's a lot of prerequisites before you start work that you have to meet those qualifications. And then, of course, we do a lot of training ourselves. We have our own nurse aid training class that we hold to get people prepared to work for us. We have certified medication courses that we teach to get people certified. We offer continuing education classes to our nurses. And we also have a scholarship fund where we will sponsor students to go and earn their nursing degree or physical therapy or anything in the allied health profession.
Now, I'm sure if there's a complaint, and in that business, I'm sure there is, like any business, do you have a procedure you go through to investigate, etc.?
Sure. We always like to hear from everybody. We take the care of our residents seriously. So if someone that they have a complaint that they don't think things are going well, everyone has got their ears open, and we always try to take care of things immediately. And we have hotlines that we publish internally that people can call to make sure that people get their questions answered.
What percentage would you say is hospitalization care, insurance care, or private pay? There are some people pay private. There's some people that are pretty well off. I'm sure they can do so.
Yes, and there again, it kind of depends on the level of care. The memory support units is primarily private pay. The independent living is primarily private pay. That short-term rehab stay where people are in the hospital, they can't go home until they get more therapy. We provide that therapy. We provide 4 hours of therapy a day, 7 days a week, so people that are able to withstand that type of rigorous exercise program and therapy program, that typically is paid by insurance or Medicare most of the time. When it comes to long-term nursing home care, there's probably a smaller percentage of people that are paying privately in that arena.
If somebody were to ask you, and this is a kind of a tricky question now, how would you cure the healthcare problem in America today? Because it's talked about every day.
Sure.
One person says it's a mess, another person says it's doing okay. It's a huge really complicated issue. Do you have any kind of maybe 3 or 4 principles to say if you do this, this, and this will happen?
Well, it would be great if it would be that simple.
Yeah, yeah, I know.
And I think with our system of healthcare in this country, what's unfortunate is it seems like every time we get a new president, anytime there's a change in leadership, we have changed how we deliver healthcare, and there's no consistency. So we are going through a period of time now that, quite frankly, is kind of a carryover from the Obama administration with the Affordable Care Act, and what the Trump administration has done to change the Affordable Care Act, even though most of it's still in place. So, and the insurance companies are becoming more involved in it, where Medicare covered health care for people over 65. Well, now you have those Medicare Advantage plans where people can switch from traditional Medicare and pick Aetna or Anthem or Medical Mutual or United or any of the big boys, and go from traditional to someone else. In the state of Ohio, the Kasich administration privatized some of the Medicaid, whether it's Buckeye, Molina, Care Source. So there's a big change afoot. So to say what's it going to be like in 10 years, 15 years, nobody can predict it, at least as far as I'm concerned. Maybe 5 years we can. But you have to be aware, you have to be on top of it. It's one of those choices I don't think people really want to make. I don't want to choose who my gas supplier is at home or who my utility supplier, my electric supplier is going to be. For some reason, people thought that was going to be important. It really is not important. It's the same way I think a lot of people think about when they turn 65, you all of a sudden have to make a decision. Do you want to stay with traditional Medicare? What about your co-insurance policy, AARP? So it's pretty complicated, and you do have to become your own expert. So to answer your question, I'm not going to because it's too complicated.
There is no answer.
There is no answer.
I remember having the Minister for Health on the radio from Ireland, and I asked him, I says, what constitutes a good healthcare system in Ireland? You know what he told me? The length of time that people were on trolleys in the hallways of the hospital. I says, what was the average length of time? And he says, oh, right now, he says it's about 46 hours.
Yes, and that is, and I see that, I read that constantly about Ireland, and that's kind of one of their benchmarks. Now, in this country, we obviously don't call them trolleys, but we also have the same stories that you'll hear. If you ever heard of someone that's going to the emergency room, it's busy, and there's no room in the emergency room, and they're in the hall of the emergency room, or they're measuring the time it takes that they're in the emergency room, they need to go to the floor up in the hospital, the acute care floor, but there's no beds available, and there's a time to wait in the emergency room. The emergency's over. They know that you no longer need to be in the emergency room, but you need to be admitted to the hospital. There's that time period.
But you don't hear much of that here, do you? I don't hear about it anyway.
No, we don't. But their hospitals do know that number. So that is an issue when the hospitals are full, and we hear that every so often that ambulances can't take them to this hospital; they have to divert to another hospital.
And I remember one time traveling on the train with my sister from Croydon to London, and I saw this incredible line of people. It was like about 3 miles long. It's more 8 o'clock in the morning. I said, "What's going on there?" She says, "They're waiting to get into the clinic." 3 miles.
Yeah.
Unbelievable. That was in England now.
And we don't, I dare say we don't have
We've
those.
never seen that here.
No, we don't. But then again, it really depends on your pay source. If you're indigent and you're in the city, it might be different than you're out in the suburbs with good health care coverage.
That's true.
And in this country, we have health care for those who can afford it and less health care for those who can't afford it.
We can't afford it.